Complications of tracheostomy. Tracheostomy is a frequent procedure utilised on the ICU for facilitation of weaning patients from mechanical ventilation. Broadly, complications can be subdivided into early, delayed, or late, which are usually post-decannulation. Risk of significant complication occurs in 16%. Incidence of death has been variably reported as between 0.16 to 2% for the procedure. Early complications occur at the time of the procedure or soon after. These can be categorized into bleeding, which can be subdivided into minor, self-tamponading, or severe, requiring intervention. Bleeding risk of percutaneous tracheostomy could be predicted by platelets of less than 50,000, an APTT of greater than 50, the presence of known bleeding disorders, cannula size internal diameter of 9 mm or greater. The use of platelet transfusions just prior to percutaneous tracheostomy has been shown to result in less bleeding for those with platelet counts of less than 50,000. Tracheoarterial fistulas occur in less than 1% of short-term or long-term tracheostomies. Pneumothorax occurs in 0.8%, surgical emphysema in 1.4%. Other early complications are pneumomediastinum, damage to the posterior tracheal wall, damage to the anterior tracheal rings, and damage to the esophagus. Damage has also been reported to the recurrent laryngeal nerve. Most studies on percutaneous tracheostomy have excluded patients on high PEEP. However, in experienced hands, it has been successfully performed on patients requiring over 10 centimeters of PEEP. Delayed complications occurring hours to days after the procedure are hemorrhage, again subdivided into minor or severe, accidental decannulation, infection, either at the stomal site or distal within the bronchial tree causing nosocomial pneumonia. The evidence is conflicting as to whether there is an increased or decreased incidence of nosocomial pneumonia with tracheostomies. Tracheal ulceration or necrosis, the formation of bronchoesophageal fistulae. Late complications, usually post-decannulation, are granuloma formation causing obstruction of the trachea, persistent sinus at the site of the tracheostomy, tracheal dilation, subglottic tracheal stenosis, which is subclinical when 10 to 25% of the cross-sectional area has been reduced, and that occurs in up to 40% of patients. Moderate stenosis, defined as 25 to 50% cross-sectional area reduction, has been identified in up to 8.3% of patients. As severe stenosis, greater than 50% cross-sectional area reduction, has been reported in the literature requiring tracheal reconstruction. Mean onset of tracheal stenosis occurring at 5 weeks post-percutaneous techniques, with a lower incidence in surgical tracheostomy, and of those that do stenose, they tend to present later in the clinical course. Other late complications are scar formation and tracheomalacia. Blockage of the tracheostomy tube by clots mucus or the wall of the trachea can occur at any time. In 2013, Critical Care published a systematic review of 8,324 percutaneous dilational tracheostomies by Marcel Simon. They identified a mean mortality rate of 2.18% for percutaneous dilational tracheostomy in that meta-analysis. However, when data for 24,300 percutaneous cases was obtained by the same researchers from departmental data obtained from personal communication with the departments who published their results, only 42 fatalities were identified. The risk of death from this data was just 0.17%. Of those deaths, hemorrhage was the most frequent cause, accounting for 38% of deaths, airway complications accounting for 29% of deaths, of which the majority were dislocation of the tracheostomy tube, and tracheal perforation accounting for 15.5% of deaths. Pneumothorax was cited as a cause of 5% of deaths, half of which were tension pneumothoraces and the other half were bilateral pneumothoraces. In terms of risk factors for complications, low operator experience was the single highest risk factor across all complication groups. Risk factors for hemorrhage were low placement within the trachea, although this could be improved with bronchoscopic guidance into the space between the first and second cartilaginous rings. Posterior wall perforation was associated with kinking of the guide wire, although once again this could be reduced with the use of bronchoscopic guidance. Risk of dislodgement of the tracheostomy tube could be reduced if sutured into position at the time of the procedure. Traditionally, tracheostomies have been sited surgically. However, since the development of percutaneous techniques from 1985, this has increasingly been performed at the bedside by intensivists. Overall complication rates appear to be similar between percutaneous and surgical techniques. There is a slightly higher risk of anterior tracheal wall injury and posterior tracheal wall perforation with percutaneous techniques. However, there is a lower incidence of infection with an odds ratio of 0.28 compared to surgical techniques. In conclusion, percutaneous dilational tracheostomy is equivalent to surgical tracheostomy in terms of complication rates, with slightly higher rates of tracheal disruption, but with lower rates of infection. The risk of significant complication is about 16%, with a procedural mortality of 0.16 to 2%. Complication rates can be reduced by experienced operators, bronchoscopic guidance, and suturing the tracheostomy tubes in place at the time of the procedure.